Our next speaker is Dr. William Bowie, who is professor of the Division of Infectious Diseases, Faculty of Medicine, University of British Columbia. Dr. Bowie.
Thanks very much. So I'd like to thank the organizers for putting this on. I'd like to thank the audience for the opportunity for us to collectively hear stories. And I'd like to thank the organizers for the opportunity and the mandate for us to collectively move forward, which I think is a goal of all of us. So I've been asked to talk about the treatment of Lyme disease, and quite a bit of what I'm going to say is quite concordant with Dr. Mahoney's comments, particularly her last slide, which has not come up in, the concept really hasn't come up in the discussion I've heard today. Treatment guidelines, whether they're for pneumonia, whether they're for whatever, are guidelines. And they always have to be interpreted in the light of the patient in front of us. And so it's been anxiety-provoking to hear a lot of the talk here, where it sounded like they're carved in stone, and clinicians and patients, along with clinicians, have no flexibility. That's just totally wrong, and that's not the intent of guidelines. Anyway, how do I move forward?
Green arrow.
Green arrow. So did this get changed? So I don't think I have any particular conflicts here. I have research funding for pneumonia from Pfizer and GSK from influenza studies. I avoid speakers bureaus. I don't do consultation fees, et cetera, et cetera. So this didn't get changed. The bottom line is I didn't understand how this conference was funded, but there's no conflicts. I do want to acknowledge that I am a member of AMI Canada and I'm a member of IDSA. And in terms of this subject, I am the AMI Canada representative to the ongoing process to revise the Lyme treatment guidelines, which are done by the IDSA, but with equal involvement of the American Academy of Neurology and the American College of Rheumatology. So we're really trying to expand the involvement of groups. So no mitigating bias is needed. So I want to take a somewhat different tact to how we develop guidelines. But first, comments about goals of eradication goals of treatment of infection. So our primary goal is to eradicate infection. And for the vast majority of infections, we actually have regimens, at least for bacterial and fungal infections, that are good at that. Next goal is to try and get the person affected back to their pre-illness baseline. Here things are a little more complicated. Improvement in signs and symptoms is usual, but not universal. And recovery of signs may be partial. So if you have endocarditis, you have infection on your heart valve, we can get rid of the infection, but you may remain highly compromised. Or if you have meningitis, or if you have septic arthritis, we get rid of the infection, but the manifestations don't necessarily go away. And then the bottom one, improvement of some symptoms, particularly subjective symptoms, may be slow and incomplete despite eradication of the infection. This is common to almost all the infections that we treat. Lyme is not unique. So what's the hierarchy of evidence that we usually use when we try to develop guidelines? And this is well established and fits well in terms of antibiotic treatment guidelines, as you're going to see next, where we can define studies pretty well. So the top is traditionally randomized controlled trials, and then cohort studies, case reports, and at the bottom is expert opinion. Clearly, expert opinion is required to interpret all of this, but if it's only expert opinion, that's really not very helpful as we come to looking at antibiotic treatment regimens. Two comments. First is the plural of anecdotes, especially unevaluated anecdotes, is not data. So stories are important, but a large number of stories that can't really be evaluated doesn't help a great deal. may identify issues, but it doesn't help in terms of developing guidelines. In terms of expert opinions, it is required to interpret data from all sources. But as I mentioned earlier, expert opinion that's not systematically acquired and evaluated doesn't constitute data. I'm just going to skip that in the interest of time. So what's the recommended evidence base for when we develop guidelines? So fortunately, any recommended antimicrobial treatment regimen is amenable to evaluation using standard and well-developed methodologies. This science is pretty good. This is pretty clear. Most typical is a randomized controlled trial where a regimen is compared with a placebo or an agent of known value. And appropriately designed studies look at not only at efficacy using hopefully some predefined endpoints, but also look at adverse events and ultimately have to come up with an assessment of risk versus benefits. So Dr. Mahoney mentioned the GRADE methodology, which is become a really well-accepted way of trying to come up with guidelines. It has many advantages. One of the advantages, again, that we've just heard about, it does include a special emphasis on outcomes and an emphasis on patient-centered wishes. All of us support that. However, I'll make the comment that all of the GRADE methodologies start off with high-quality data where defined regimens are assessed and compared. So how are these questions asked when we develop guidelines? So we use a framework, a Pico framework. So a typical study has a clearly defined population. So we try to articulate the patient population and the question that applies in that patient population. We have an intervention, which is usually a specific regimen under study with a drug, a defined dose, and a defined duration of the drug. A comparator, which could be another placebo or another drug, and then we have the predetermined outcomes. So coming to Lyme, I don't deal with any other infection where there's such controversy around the issue of treatments. And I would argue that there's a lot of confusion, if not worse, in terms of terminology around Lyme disease. I'm going to break it down subsequently. But the terms used to encompass a range of folk where there's no question about diagnosis of Lyme disease, all the way to those who have little or no evidence of active infection. And many of the so-called treatments that are recommended have never been subjected to this initial stage of actually demonstrating activity of a specific regimen versus a standard, let alone looking at benefits versus harm. So this is a slide I've used now for a decade or more around lab diagnosis, but it's totally applicable to the treatment. So on the left, where it says public health laboratory, we have the IDSA type guidelines. On the right, we have the ILADS recommendations. Across the top, we have kind of irreconcilable recommendations, but who's caught in the middle? Well, thanks very much. So patients and the families and supporters of patients, it's healthcare providers, it's public health officials, and the media. Stuck right in the middle of this issue that we can't find a way around. So how do we move forward? So we can certainly clarify terminology, and I'm going to argue we should be assessing data and studies according to specific groups. And then looking further forward, we can try to figure out how do we fill these gaps of knowledge. And I've said here, hold accountable those who promote treatments without conclusive baseline supportive evidence. I don't mean punitive. I mean raising the question, holding all of us to account on how solid is the data on which you make recommendations. So what are the categories that are labeled Lyme disease? And David Patrick used this morning, not surprisingly, since we work in the same group and we've worked on this issue a long time. So the first category are people who have Lyme disease, and no one's particularly going to dispute that. The second category is what we're hearing about a fair amount here, are people who are given a label such as post-treatment Lyme disease, where they had clear evidence of Lyme disease as in category number 1, but they have incomplete resolution of symptoms after standard antimicrobial therapy. The next one is the one that David Patrick was particularly talking about, those who have alternately diagnosed Lyme disease, where folks are diagnosed on clinical grounds, but the only positive laboratory testing is when it's done by labs where we question the results. So I can name IGeneX for an example, which is a recurring theme. And then there's a fourth category of people who are diagnosed purely on clinical grounds, and if any testing is done, they test seronegative for Lyme at a time beyond the initial stage of Lyme disease, where we would expect most of them to have positive tests if they have active Lyme disease. So what about the quality of the data supporting treatment recommendations? So for group 1, which are essentially IDSA-type guidelines, these are based by and large on well-designed studies that, in our opinion, provide sufficient evidence to support the guidelines, even though there are always going to be questions. You can't answer all questions in a guideline. None of our recommendations are for treatment beyond 4 weeks of therapy. And in the vast majority of people that are treated according to these guidelines, people improve. What about the quality of the data behind groups 2, 3, and 4? So we're going to have some differences of opinion here, but none of the studies, including the study from the Netherlands, in my opinion and the opinion of my colleagues, provide convincing evidence of benefit of longer course therapies. And for these non-IDSA type treatments, there are no studies demonstrating efficacy of those treatments, let alone studies looking at assessment of real or potential harm and overall cost of the studies. So I'm going to not go through this study. It's been mentioned several times, except to make, so there's a recent Netherlands study, the comparison of ceftriaxone and then longer course therapy. I don't have a pointer here, but I point out that participants usually were highly symptomatic for at least 2 years. Most of them had received antibiotics for 30 to 40 days, and most had received 2 or more courses. And the outcome is a bizarre study. I don't think anybody in this room likes this study and the design of the study. But what it shows is, well, it shows a couple things. Firstly, 50 at the top is what the general population would be in terms of health status, and the lower end of the number, the worse the health status. So this is a group of people who are significantly compromised by symptoms. But I interpret this data to say that there's no obvious benefit of giving antibiotics beyond the 2-week course of ceftriaxone, and that antibiotics were no better than placebo. Now, I'm sure one can do some subgroup analysis and tease out little bits of this, that, and other thing, but those really aren't a traditional way of doing a study. The stupidity of this study, well, there are many stupidities. Unfortunately, they didn't do an evaluation after the 2 weeks of the ceftriaxone. So we don't actually know when that apparent improvement between 0 weeks and 14 weeks actually occurred. So it makes it difficult to interpret a lot of the benefit, but it makes me feel fairly comfortable. I don't see any added benefit of 12 weeks of antibiotics. I'm going to talk just really briefly about the ILADS guidelines. So, as we've heard, the data that IDSA used are looked at differently, and there's a belief system that the traditional shorter courses of therapies aren't adequate. However, the recommendation is based on very low quality evidence. We should be able to do better than that when it comes to treatment trials with antibiotics. And then if you look at continuation of therapy, long course therapy, at least 4 to 6 weeks, for which there's no evidence from randomized studies. And then there's this approach that we don't do in any other infection. If there's strong to moderate response, well, give therapy longer. If there's not a very good response, increase the dose or switch to a different drug. And if there's no response, then switch to combination of first-line agent. There are no data that support that this actually works. So there's been a lot of discussion about what are the potential harms of this. Well, there are lots. Desperate and vulnerable folks may be given an incorrect label and subjected to unproven treatment for which there's no valid evidence of benefit, let alone the benefits exceed risk. There's a focus on Lyme to the exclusion of other possibilities. There are risks of antimicrobials to oneself, and there are risks of antimicrobials to the community at large. The debate or angst that we have between the different groups severely undermines medicine and public health. We do not develop guidelines for Lyme disease differently from all other diseases. We use the same methodology for hypertension, for diabetes, for all other infections. And so some of the debate is actually undermining particularly our public health colleagues and those of us who develop guidelines. So it undermines all of us. And then I have the new issue. I now treat people with acute Lyme who now fear for their lives, even though they have really treatable disease. They're now scared stiff that they're going to develop long-term consequences. Oops. So my comment, which may be taken as inflammatory, but I feel it strongly, the ILAD site recommendations have gone on for a couple of decades. There have been huge number of people exposed to these treatment regimens. There ought to have been an opportunity to actually evaluate those regimens. I think that's a reasonable expectation. And certainly it constitutes missed opportunities to help provide better evidence-based care. So what could a potential study look like? I'm not driving this study, but in any other infection, we define a population. So in this case, individuals who meet criteria for example, alternately diagnosed Lyme disease, and one could define that, a level of disability, et cetera, et cetera. We have an intervention, which I've said doxycycline, 100 milligrams twice daily for 6 months, but it could be any regimen. There should be a comparator. I would argue, given the total absence of data that these regimens actually make a difference, it probably could and should be a placebo-controlled study. And pre-specified outcome measures should be defined. So the health-related quality of life and related measures, which has become a bit of a standard for a lot of these studies, and then secondary analysis of adverse events. So moving forward, we're all concerned about the profound disabilities that people in categories 2 to 4 have. People deserve formal evaluations of treatments given to them, as well as better efforts to understand what's going on, and that focusing on a perceived diagnosis of Lyme disease actually has the potential to be highly detrimental. So what are recommendations? So although this meeting is based around Lyme disease, I think most of us would argue that Health Canada could and should use this opportunity to better understand and support individuals with chronic debilitating manifestations, whether or not it has anything to do with Lyme disease. Then final two comments. Guidelines are always going to be incomplete, particularly with tick-transmitted pathogens, where they're new pathogens, they're spreading geographically, and new knowledge accrues. So no guideline should ever be carved in stone. And we all must be prepared to revise our understanding of disease and treatments as high-quality new knowledge is acquired or developed. And this ability to change tack with new data is at the core of scientific method. That's it.